Thank you. Good afternoon. I appreciate you being here. I'm Dr. Don Blanton. I'm board certified in internal medicine and emergency medicine, and have been working in the area of clinical documentation integrity for the past couple years, helping medical centers and their medical staffs negotiate all these changes with healthcare. Prior to that, I spent more than 25 years full-time in emergency medicine, was on the faculty at Vanderbilt when we created the residency program there in emergency medicine. And but I'm really enjoying this. We're going to talk about ICD-10 for sure, but there's a lot going on around ICD-10 that's going to affect us, our practice revenues and the public portrayal of our reputation that's important to know the background of. So we're going to talk about risk adjustments a little bit and how they're used, quality, cost efficiency analysis, our changing reimbursement environment, and we're going to talk about clinical conditions as represented in the literature, so we can use the appropriate terminology and identify the terminology that the coding system uses to give us credit for what we do. So ICD-10's coming October the 1st. There's not going to be any more delay. Big increase in the number of diagnostic codes from just short of 15,000 in ICD-9 to almost 70,000 in ICD-10. In the arena of OB, they almost but not quite double. The number of procedure codes just really expands. Most of the increase in the number of the codes have to do with the musculoskeletal system. A full third of them are just adding left and right. So any organ that has an enantiomer, so to speak, a left and right, we need to remember to document that. For many things there are bilateral options, and for many things there is an unspecified option, but we recommend using caution with the unspecified codes, because if payers know, we know if it's left or right, and we don't say, it gives them an excuse not to pay. Medicare has announced they're giving us a 1-year grace period on errors like that, but we don't know about Medi-Cal, we don't know about Blue Cross, Aetna, any of the privates. So just a little caution there. So this is the ICD-9 code structure, 5 digits. In ICD-10 we're going to 7 digits, much more room for expansion, and the procedure codes are expanded dramatically as well. And this is an example when we're lysing adhesions. There are codes available for every body part that we are freeing from adhesions. So left and right, of course, fallopian tube, ovary, uterus, there are codes for each of those. This is a screenshot taken from the actual procedural coding system table. So you can see we've got left and right ovaries, bilateral, supporting structure, left and right fallopian tubes, bilateral, and so there's a great amount of detail. So if you're lysing adhesions from ovary, fallopian tube, and the body of the uterus, there are codes for all of those. And each additional code adds to the representation of the complexity of the patient. And as we are going to be graded for cost efficiency and quality of care, it's the total accumulation of those codes that describe our patient's complexity of care. And particularly when we get into some of the medical secondary diagnoses, all of these comparisons are risk adjusted, which means graded on a curve. So if you're looking at deliveries that are complicated by, say, diabetes and morbid obesity, when they're looking at readmission rates or infection rates or whatever like that, we're being compared to other patients that have diabetes and morbid obesity. When we don't include those, then they're not available for comparison, so we may not look as good on paper as we actually clinically are. So that's a big impetus for us to pay more attention to these kind of details in secondary diagnoses. A little bit about risk adjustment. That's why a life insurance policy for a 16-year-old costs less than a 60-year-old that smokes 3 packs of cigarettes a day. So all of these evaluations are risk adjusted, graded on a curve. They compare outcomes that are observed, what we record on the record, versus expected outcomes. And that gives us an idea of risk-adjusted outcomes measurement. So if the height of this bracket represents my patient's true, total, complete complexity of illness, but the height of this bracket, because of how I document, allows the coder only to report the patient as this sick, then this is kind of a danger area. I'm taking care of somebody that's sick, but I'm being compared to other patients that are this sick. So it's this documentation gap that's the difference between my patient's true severity of illness and its representation, and it depends entirely on the language that we use to document in the record. There are some terms that we use frequently that the coding system just has not assigned relative weight to, and we need to understand what those are so we can adjust ourselves appropriately. Because this pool of other patients to whom my care is compared depends not on how sick my patient is, but how sick my patient looks on paper to the coder. And we want to reduce down coding, we want to reduce just abject denials of payment. We want our quality portrayals to be accurate and our cost efficiency portrayals to be accurate. Just a little bit about these languages that our medical language is translated into. The first two are inpatient only. The MSDRGs are used by Medicare, obviously. It's Medicare severity diagnostic related groups. Many private insurance companies use this methodology. The APR-DRG methodology is used by Medi-Cal, which is very prominent in your patient population. And then there are HCC, hierarchical condition categories. These ICD-9 and ICD-10 codes accumulate only from inpatient admissions. These codes accumulate from wherever they're diagnosed, whether inpatient or outpatient. And these are the languages that are used for billing, reimbursement, and all the statistical analysis, and they're designed to communicate the patient's severity of illness to the world, essentially, of processing and bureaucracy. Because they're not looking at our charts, they're just looking at the billing records that are attached to these numbers. So briefly, there are three thresholds of severity within the Medicare MSDRG system that describe the secondary diagnoses: CCs, major CCs, and neither one. In the CCs, the first C stands for comorbidities. It's those conditions that the patient brings with them to the hospital. They're chronic conditions like their pregnancy, hypertension, diabetes, and anything new that happens, their pneumonia, stroke, heart attack, that sort of thing. The other C, complication, are those things that arise after the inpatient order is written. And a major CC is just a higher severity, so the three tiers are MCC, CC, and then neither one, and it's those terms for which we get no increased credit at all. In the APR-DRG system, two categories: severity of illness and risk of mortality, and each of these has a number between 1 and 4, 1 not very sick, 4 very sick. And the two numbers can be different. You can have a high severity of illness, a low risk of mortality, so the numbers don't have to be the same. And then the hierarchical condition categories have fractions of numbers attached to every secondary diagnosis, and you just add those up together to get a total risk adjusted factor that reflects the patient's severity of illness. And because these are accumulated from outpatient settings as well, sometimes they're called outpatient DRGs. Now within the MSDRG, just examples of terms that I used all the time in my practice of emergency medicine: altered mental status and unresponsive. They're symptoms. They give you no clue as to what's going on. We get no credit for that. I had no idea. But if we can define what's causing the alteration in mental status, such as a delirium, or even classify it as a toxic encephalopathy if it's due to a medication effect, or a metabolic encephalopathy if they're hyponatremic or septic, that sort of thing, then these are categories in the highest level of credit. And the cardiologists are struggling even with heart failure. And when we went to medical school and somebody had an exacerbation of heart failure, we just called it CHF. But now to get credit for it, we have to define why it's different today than last week, because they had heart failure last week, they weren't in the hospital. What's different? They had an acute exacerbation. So for symptoms, we get no increased credit. For functionality and acuity, we get great increased relative weight credit. Now, it's this HCC methodology that they're using to adjust Medicare payments based on the physician value-based payment program. I know your Medicare population is pretty thin in these areas, but this is the methodology that they use to identify the cost per beneficiary, and it's also the methodology they use to fund ACOs, accountable care organizations, and independent practice organizations. Now, all diagnoses have to be made in ICD-10 regardless of where they're made. Inpatient, outpatients, ERs, they all have to be coded into ICD-10. The facilities are the only ones that use the ICD-10 procedural coding system, and then only for inpatients. So if you do office procedures, it's only CPT coding. If you do same-day surgery, that's just CPT coding. Outpatient surgery centers, CPT coding. If the patient is in the hospital in observation status, they're still not an inpatient, so that's just CPT only. With this one caveat: if they get admitted to the hospital as an inpatient within 3 days of performing that procedure, the hospital has to code it and bill it in ICD-10 procedural coding system. But CPT does not change. We still send CPT charges from the office, from the hospital, for procedures in that. Now, in the changing reimbursement environment, it's happening first with the orthopedist. Medicare has announced that beginning January the 1st of next year, for total hip replacements and knee replacements, they're going to be reimbursed in a bundled payment. So instead of every stakeholder getting their own check, the hospital sends a bill, gets a check, the orthopedist sends a bill, gets a check, anesthesiologist, the radiologist, there's going to be one check that's going to go to the hospital or an accountable care organization, and that pie is going to get sliced up and divvied out to all the stakeholders. So what we can do is make sure that the size of that pie is correct. The procedure, the reimbursement is based on the procedure, but all the secondary diagnoses that identify the patient as a little more complex, a little sicker, those add up to make the size of the pie bigger. So now we're interested in those things. The orthopedists in particular never cared about those secondary diagnoses because they got paid on the procedure and it didn't make any difference. And now they're having to pay attention to that. And bundled payments have been tried in pilot programs now for a few years, and many hospitals are having great success with that. It's making communication better, efficiencies of returning labs, imaging reports, and coordinating discharge planning and the like. Now, Integrated Healthcare is based in Oakland, and they have been working with bundled payments in the obstetric area for a while, and are having some success with that. And under their gain-sharing demonstration, their bundle essentially covers the entire pregnancy in the first 2 months postpartum. And these are the different DRG numbers assigned with C-section, and these no secondary diagnosis that adds credit. And this is a secondary diagnosis that is mid-range, and these additional procedures with which you're familiar. And there are bundled payment plans for all of these. And all of these components, preoperative testing, delivery, ultrasound, all of those things are covered with the bundle. Now, the size of the bundle can be affected by these secondary diagnoses, whether they have infections, develop anemia, their baseline medical history includes asthma, bipolar disease, other instances that complicate pregnancy. All of those have ICD-9 and ICD-10 codes, and when we accumulate those, the patient looks more complex, and that eventually accrues to our credit toward establishing the patient's severity of illness. Their length of hospitalization is what it is. How much we spend to accomplish that care is what it is. So the sicker they look in those parameters, the higher quality and more cost efficient we look. Other potential risk adjusters, just things we identify as secondary diagnoses that affect how we approach the patient, and we get credit for that when we document them. So here, vaginal deliveries and cesarean deliveries, and within the Medicaid APR system, the simple ones, level 1s, not so sick, up to 4 with the most secondary illnesses. And you can see how the relative weights go up with those, and the bundles go up too. So this makes a huge difference when we're slicing that pie and dividing it up to all the stakeholders with the size of the monetary bundle, the size of the monetary pie that we're dividing up. And so we have great influence on this. These are some things, for example, an obese woman undergoing C-section uses unprescribed oxycodone and has anemia post-procedure. A little bit more complex care involves somebody with acute blood loss anemia or has an opioid dependency. If a woman has a body mass index of 40 or greater, they're morbidly obese. That complicates things. If there happens to be major organ dysfunctions, sepsis or severe sepsis, and you can see it at these increasing levels of severity of illness, complexity, the bundle goes up too. The amount of the monetary bundle is the relative weights multiplied by the base rate, and the relative weights also accrue to identify our quality of care, because the sicker the patient looks, the better we look in accomplishing all that. So here's uterine and adnexa procedure for malignancy. How you can see this is no secondary diagnosis. This is a secondary diagnosis at that middle level of credit of a CC and the highest level of severity in MCC. And you can see how the relative weights go up, and the bundle goes up as well quite dramatically. But also sort of hidden within this, the more complex the patient appears on paper, there are increased days of expected length of stay. I don't know if you ever have pressure, to get patients out of the hospital because we're getting toward the end of our length of stay expected. So these just magically appear as well. It's a complex system. So these are some commonly missed diagnoses that we see in reviewing charts for Medi-Cal. When the maternal age is older than 35, anemias, electrolyte abnormalities, insufficient prenatal care, lacerations and they're repaired, maternal drug dependence. We just need to be sure we note them when we see them. Anytime we can link a condition and its cause, or a condition and its consequences, very frequently that raises the relative weight. So if somebody has anemia, if we can name it acute blood loss anemia, that's higher weighted. So with OB cases, some common secondary diagnoses at the middle level of a CC, acute blood loss anemia. It's my understanding with a C-section, you expect to lose about 1 liter of blood. That's just integral to the procedure. We can document that as acute blood loss anemia. There's no requirement for the diagnosis of acute blood loss anemia of a transfusion. You don't have to transfuse. I've asked other obstetricians and they'll say, yeah, we'll let them go home with a hematocrit of 21, 22. They're young, healthy people. They'll be all right. And it does not automatically code as a complication either. That's very important to know. That's very comforting to know. You can diagnose acute blood loss anemia and it's not going to ring somebody's light as a complication. Urinary tract infections, sometimes secondary diagnoses that are established as an outpatient. The primary care physician may know about them, but they may not play directly in your delivery of care. But if we list them, it adds to our complexity of illness. We're human beings taking care of human beings, so a lot of them are on meth and a lot of them are addicted to opioids and alcohol is an issue. And there are categories called complicating diagnoses, which include preeclampsia or hypertension, but for some reason if we just use the term high blood pressure, we don't get any credit for that. Postpartum hemorrhage, obesities and anemias that complicate childbirth, drug, alcohol, nicotine use. With any of these, if any of these patients have symptoms of withdrawal, if we document that they are demonstrating symptoms of withdrawal, that is a secondary diagnosis at that middle level. So if you have a smoker that's prescribed Chantix or wearing a Nicoderm patch or chewing Nicoderm chewing gum, nicotine chewing gum, then they are treating symptoms of withdrawal. And when we note that, it's like you're taking glyburide to treat diabetes. Your blood sugar may be normal, your hemoglobin A1C may be normal, but we're using that medication to treat the diabetes. Well, if you're using nicotine to treat withdrawal symptoms, then we get credit for that. So if we say nicotine dependent withdrawal symptoms controlled with whatever they're taking, if they're taking something, and also if you're standing in the hallway arguing with them to get back in the room when they want to go outside so they can smoke, that's symptomatic nicotine withdrawal. I don't know how many times I've had to do that. And if somebody's alcoholic and a little tremulous, then we get credit for that. If somebody's opioid dependent and we notice that they're diaphoretic and having their piloerections from withdrawal symptoms, then we note the withdrawal symptoms, we get extra credit for that. And I would say appropriate credit for that because we're having to deal with those things. New or significant issues in the GYN area, laterality we talked about, specificity of acuity, acute, subacute, or chronic. If somebody has a chronic condition and it's worse and requires them to be in the hospital, we need to explain to the system why it's worse. Like asthma, they had asthma last week, they weren't in the hospital. What happened? Well, they have an acute exacerbation or they're having status asthmaticus. Specificity of location. In ICD-10, salpingitis and oophoritis were coded the same. In ICD-10, they can be one or the other or both. And anatomic location, as we saw on the diagram. Specificity of conditions. If we know the organism, if there's peritonitis, that is significantly increased relative weight than just saying pelvic inflammatory disease. And here's an example of acute salpingitis, acute oophoritis, or both. For chronic salpingitis, we get no credit. If we just say salpingitis without specifying its acuity, we get no credit for it at all. And in the APR system that Medi-Cal uses, we get the most minimal credit of it. There are no zeros in these categories. The lowest they go is 1, so this is as low as you get. If we describe the acute salpingitis, the severity of illness is 2, the risk of mortality is very low, so that number doesn't change. Premature rupture of membranes when labor begins within 24 hours of the rupture is a different code than when there's premature rupture of the membranes and labor onset is greater than 24 hours. So noting the duration, the interim of time between rupture and onset of labor is significant. And we've talked about risk-adjusted outcomes. They look at complications as well, observed complications versus expected complications, and we can influence this category by describing our patients to be as complex and as detailed as they are. Now, the observed complications are determined by the patient characteristics and the quality of care, and the expected complications, that group of patients to whom our care is compared, is determined by our documentation and how that documentation can be translated into the coding languages of ICD-9 and ICD-10. So the more detailed we can get with including all the secondary diagnoses and using the language that the coders can use to grant us credit, that helps those determinants. Now, in the coding system, if there's a 3rd degree or a 4th degree perineal laceration, the Agency for Healthcare Research and Quality Patient Safety Indicator, it has a number in these columns. So they ding us when there's a 3rd and 4th degree laceration, but they happen sometimes. I understand that they're trying to discourage episiotomies. So how do you win here? So you know what these are and the repair required of them. So when we do it, we just document it. Now this is a table that represents terminology for which we get no credit, terminology for which we get some increased credit, and terminology for which we get a great amount of credit. Acute blood loss anemia, postpartum hemorrhage, we get credit for that. Acute tubo-ovarian abscess or salpingitis, partial credit for that. But if they are septic, then we get increased relative weight at the highest level for that. And we've already been discussing postpartum hemorrhage a bit, and there are different strategies for trying to quantitate it. Some people, weigh the towels and try to estimate the blood loss. And this is the California Maternal Quality Care Collaborative. We've actually, used this as a reference to hospitals outside of California that we visit, because this is a very good baseline and learning tool. And postpartum hemorrhage, there are exclusions to these patient safety indicators. If somebody has retained placenta, then it's not included in the complication rate, so we need to note that when it happens. There are different codes in ICD-10 for events that occur intraoperatively versus post-procedural things. Intraoperative bleeding, they're very forgiving of, but if there's post-procedural hemorrhage, then it highlights that patient safety indicator issue. And in some reimbursement mechanisms with this, you see there's an increased relative weight at the level of a CC for intraoperative hemorrhage and also for post-procedural hemorrhages. But when there's this alert here, we don't get this credit accrued to us toward our quality of care, and the hospital doesn't get this increased relative weight toward its heavier weighted DRG. The reimbursement would be the same as if this never happened. So we don't get increased funds for caring for this additional thing. It's just, it's all carrots and sticks. Now, with hemorrhage and with complications in general, it hinges around whether whatever we're describing, in this instance hemorrhage, is integral to the procedure itself, is expected, or is unexpected. So if it's integral to or expected amount of bleeding or whatever you find, I mean, if you're doing a procedure and there are no adhesions and something gets nicked, that may be unexpected. If you're doing a procedure and there are adhesions everywhere and something gets nicked, that may just be integral to that complicated procedure. So when we include terms like that in our operative note, you can tell the coder how to code that, and they can code it accurately and not have to bother you with the query after the fact. Since I mentioned the term query, the coding rules are very arbitrary and in many instances unhelpful, and in the area of queries they are unhelpful. If we have a patient that is obviously anemic, they're admitted, hematocrit and hemoglobin are this, a few days later for whatever reason it's this, and we never use the word anemia, they can present the numbers to us for our review and say what's the clinical significance of this. But if we haven't used the term anemia, neither can they. They can't ask you, is this consistent with acute blood loss anemia? Because we didn't use the term. So the queries sometimes come to us as if they're from outer space someplace. I mean, they're indirect, and so physicians can interpret that as the coder not knowing what they're asking, not knowing what they're talking about. It's because they can't. It's just one of those arbitrary rules. Years ago they could, but for the past 10 years or so they've not been able to. They're not permitted to introduce a term or a condition not already established in the record. And that can be a source of great frustration to physicians. And here's the slide about acute blood loss anemia. 20% drop in hematocrit, 2 gram per deciliter drop in the hemoglobin, transfusion of 2 units of blood or more. But the transfusion is not required. It's not automatically coded as a complication of procedure. All conditions that are identified during the pregnancy are deemed to be related to the pregnancy unless we state explicitly otherwise. If somebody has, presents with a laceration of their knee or something because they fell, totally unrelated to the pregnancy in either way, then the coder needs to be made aware that that's unrelated to the pregnancy. Now, when we were taking our training to be ICD-10 approved trainers, they made a big deal about the fact that many of the codes record the pregnancy in whatever trimester it's in, rather than weeks of gestation. But then they told us that, well, the coders can take weeks of gestation and just look at the table and see what trimester that's in. So now all of a sudden, it's no big deal to me, because we always document in weeks, right? I mean, would you ever see a pregnant patient and not note their weeks of gestation? We always do. So the coders can calculate the trimester from the documented weeks of gestation, so it's not that big a deal. Now, they've changed the demarcation of what they call early versus late pregnancy. Used to be 22 weeks, now it's 20 weeks. I don't know, did the obstetric literature do that, or is it just a coding thing that they made up? I'm unable to answer that question. It may have impact, if somebody delivers at 21 weeks, now you can code it as a delivery rather than a miscarriage or a spontaneous abortion. And there's so many of these lines of demarcation are so arbitrary. Now, with multiple gestations, they have different codes for different fetuses. Now, there are codes in pregnancy, childbirth, and puerperium. Does your office staff do their own coding? This would be more helpful for them. These codes in ICD-10 start with the letter O, not 0. And it's important when we identify secondary diagnoses or problems that complicate pregnancy versus normal delivery, because you can't use the supervision of normal pregnancy code, Z34, if there's something else going on with the patient, some secondary diagnosis or something that's complicating pregnancy. So if they have morbid obesity or complicated by alcohol use, then that wouldn't classify as the normal pregnancy. And you can see how the codes are by trimester. Now, just this table in general is a general equivalence map. ICD-9 code in this column, its description. ICD-10 code in this column and its description. And you can see there's one code in I-9 for the hydatidiform mole, but there are 3 options in ICD-10. Now, one thing we are providing for you is a digital version of this table that has every ICD-9 code in it, not just the ones that apply to OB-GYN, but it's searchable. You can type a word up here and it will go to, like if you typed in hydatidiform mole, it would come to here. And many of the things of which you are interested are in this neighborhood on the table, but the tables, you don't print this, it's 2,400 pages long. You'll run out of yellow ink. And so this can kind of give you an idea. It may be helpful to your office staff to look at your top 10, 15, 20, 50 codes in ICD-9 to see what the options are in 10 so they can kind of get comfortable with those options. And so come October 1st, it's just another day of the week. High-risk pregnancies, history of preterm labor, and other things that there are different codes for all those high-risk pregnancies. And you can see how identifying these can add up. Grand multiparity in 5 or more births. In the ER, we just call those, holy cow. Diabetes in pregnancy, type 1 versus type 2, obviously. When there is an underlying cause of it other than what most are, whether it's a secondary to a drug effect, a previous illness, that sort of thing, drug or chemical, there are different codes for that. And any complication that a patient has, diabetic gastroparesis, that links the condition and the consequence. But anytime we can link the condition and the consequence, or the condition and cause, it's the relative weight goes up. Not so much in your patient population, but we see diabetics all the time, and we see older people with non-pressure ulcers, but we hardly ever say due to diabetes or diabetic non-pressure ulcer, but we get increased relative weight when we do. So it's just, we're having to change our ways of thinking and habit. Pre-existing diabetes, when you get pregnant, it adds relative weight, but gestational diabetes does not add relative weight. I don't know why they decided that. Eclampsia and pre-eclampsia, if we designate the trimester of involvement, we get extra credit in the second and third trimesters, but when we don't give the gestational age, we don't get any credit at all. And gestational hypertension does not add weight, but if they were hypertensive before the pregnancy, we do get increased weight for that. And this is a screenshot from another table that we will provide for you. Every ICD-10 code, its description, and its relative weight assigned in the Medi-Cal APR-DRG system or the Medicare DRG system, whether it's a CC, an MCC, not depicted here, or neither. And Medicare has a list of hospital-acquired conditions like DVTs, pulmonary emboli, pressure ulcers, that if they originate after the inpatient order is written, even though there may be increased relative weight on the table assigned to it, if it arises after the inpatient order, we don't get that credit. The hospital doesn't get that credit. Everybody just has to eat it. For every diagnosis, every single ICD-9 code that goes on the billing record, they have to say for each one, present on admission, yes or no, for every single one. Most of the time it's obvious, they don't bother you. But when it's not clear, they may have to query that. They can only code from licensed practitioners' documentation with face-to-face contact with the patient, which is why they can't code from the cardiologist's EKG report, because they never saw the patient. When I would see a patient in the emergency department with congestive heart failure, and we give them a bunch of Lasix, if it was a female, the nurses would just put a Foley catheter in there and then come back, would you write an order for the Foley catheter we just put in there? And now you can't do that, because the number one cause of urinary tract infections is Foley catheters, and so we just have to change what we do. For the HELP syndrome, there are new codes for that, and this table too will tell you, as most of them explode and with more options in ICD-10, and this will tell you whether it's an exact match, not displayed here, or an approximate match, or there are just so many new options you really need to go to the tables and look at them. Complicating issues in pregnancy, obesity is one, due to excess calories. I'm not sure. What else causes obesity? I'm not real clear on that one. You've enlightened me greatly today already. If you got any advice here, I don't know. I've learned that the key to weight loss is what you don't put in your mouth. Other complicating issues, alcohol use, drug use, smoking, and so we get credit for these if they have this. If they have withdrawal symptoms from any of those, we get increased relative weight for that as well. For opiate use, abuse, dependence. So we're being asked to describe a few more of the trees to justify calling it a forest. So my partner, Dr. Kennedy, who's been doing this for way longer than a decade, created this mnemonic music. We're from Nashville, easy for us to remember. The M stands for manifestations, signs, symptoms, syndromes, the first thing you hear, the first thing you see. U, the underlying cause. S makes us pause to think about severity, specificity, make sure we write left and right when they've got another one on the other side. If they have the UTI, do they meet the criteria for sepsis? Is there something else going on? Instigating or precipitating causes, and consequences or complications. When we identify a condition and plug it into the mnemonic and ponder these other areas, anytime we can link condition and caused by, due to, resulting in, it very frequently increases the relative weight. And Dr. Kennedy also came up with this rule of 3 to establish the clinical validity. I can diagnose sepsis, today in a progress note, and if that's the only place that word appears in the chart, the coders can legitimately code sepsis. But the review audit contractor will say, you just mentioned that once, it's not in the H&P, it's not in another progress note, it's not on the discharge summary, so we don't think they really had that, so we're taking that money away from you. That's how they make their money, taking money away from the hospitals. And so we want every condition, noted at least 3 times. H&P, progress note, another progress note, or the discharge summary. The discharge summary is the most important document because it describes the conditions that the patient presented with, how we identified those, how we named them, how we intervened upon them, how they responded to that, and what we expect the post-hospital course to go. So it's the most important record, but it's not always perfect. You know, I've reviewed charts at almost every hospital which I've been. Patient hospitalized for pneumonia, treated for pneumonia, recovering from their pneumonia. You look at the discharge summary, the word pneumonia is not even anywhere on there. It happens. The patient gets better, we get distracted, we forget, we're busy, we move on. So Dr. Kennedy and I are competitively OCD, so I thought it'd be fun to have 3 rules of 3 just to make the trifecta. So I created 2 more. 3 parts of speech: the noun, the condition itself, the adjective that describes it, the acuity, acute, chronic, acute on chronic. If it's a condition they had last week and weren't in the hospital, why are they in the hospital this week? Linking condition and cause, and once they're in the hospital, how's it going? Better, worse, same, resolved. And with the verb, the 3rd part of speech is the verb. What are we going to do about it? What are we doing about it? What did we do about it? And then number 3, and this one to me is the most important. Once on the problem list, always on the problem list. Things get better. You know, infections go away, fevers go away, anemia, we may transfuse it, get better, we forget about it, pneumonia improves. So we want to preserve those conditions for the discharge summary so we get credit for those. Lawyers will tell us that if we didn't document it, we didn't do it. The payers tell us if we didn't document it, we didn't diagnose it. What we say, if we didn't document it, we can't get credit for it. We want our patient's true, accurate, total, complete complexity of illness to be described in language on the medical record that the coders can use to give us credit for it as they translate our language into the administrative languages of ICD-9 and ICD-10. Because we want to eliminate downcoding, we want to eliminate denials of payment based on an inadequate representation of the medical necessity for whatever service we provided or procedure we performed. And remember, medical necessity is in the eyes of the payer, not in the eyes of the physician. And we want our quality portrayal for sure to be accurate and our cost efficiency portrayal to be accurate. Michelangelo at age 87 said, "Yet I am learning. If people knew how hard I had to work to gain my mastery, it would not seem so wonderful at all." You people have worked very hard to get where you are. I will include myself in that. And we don't want to get credit for what we do. We want to get credit for what we do. And it's never been harder, it's never been more important. But hopefully this, little bit of background, a little bit of motivation, a little bit of understanding of what they're doing with the ICD-10 codes after they leave the hospital will help us understand why we need to tweak our thinking a little bit just to give ourselves credit for what we do. Thank you for your time. I greatly appreciate that. Thank you.